So all three of us are here.
We're here.
I'm Danielle Aberman, and on the screen is Eileen Zollinger and Dr. Yablon.
Hi, nice to meet you.
Hi, doctor. I'm sorry I missed our call last week. I am still fighting the cold or whatever I have that kept me off of that. So it's nice to meet you. Everybody, we'll go ahead and give you a little bit of information about Dr. Lisa Yablon. She is a headache specialist with NeuroHealth, which is the online headache clinic that we've been talking about quite a bit at Migraine Strong, because we're just so excited that they're available for everybody to be able to use them for telemedicine. So definitely check that out. She takes a special interest in migraine during pregnancy as well as menstrual migraine. So we're going to talk about that today.
Sounds great.
Can you tell us a little bit why you're so interested in menstrual migraine?
Sure. Well, I mean, obviously migraine is very much more a problem of women of reproductive age. You know, peak time for migraines is teens, 20s, 30s, 40s. And yet obviously many migraine doctors are also males, and so may not have so much consciousness of you know, the issues involved in that menstrually related migraine, and also migraine when you're planning pregnancy, and also when you are pregnant and during breastfeeding. And so, yeah, it was just something that was near and dear to me, in addition to which I have migraines myself and menstrually related migraine. And so it was some, you know, a challenge that I had to deal with on a personal level as well.
Mm-hmm. Okay. I noticed you said menstrual related migraine. Can you just tell us the difference between menstrual related and menstrual migraine?
I don't know that there's really a significant difference. That's just the more medical term that is used.
Okay. Okay. Well, we had so much interest and so many questions that we decided to put them in different categories. So how we'll handle this is I will ask some questions in a category, and then Eileen will, and we'll just go back and forth a little bit, because some of the questions were repetitive, and I think in your answers you'll probably also answer some of the ones that that were lower on the list. So the first question that I have for you is, why is the migraine brain so sensitive to fluctuating hormones?
Well, that's a good question. I mean, migraine brains just in general are very sensitive to fluctuating everything. Fluctuating sleep schedules, fluctuating hydration status, fluctuating moods and, you know, anxiety levels. You know, exposures to different foods. And basically the way I describe it to patients is that a migraine brain just likes things to be very stable. You know, there are different things that we see in relation to the peaks and troughs in hormones, specifically in estrogen, that can impact on people's migraines. First, we see a spike. You know, that's when the estrogen levels are at their maximum in, you know, in a natural hormonal cycle. And in relation to that is when we normally will see people developing migraine with aura. You know, auras are most likely to occur around the time of ovulation. And then similarly further in the month, you know, usually towards the end of the cycle, as you're about to get your period, that's when the estrogen levels will drop. And that's when people are most likely to develop menstrually related migraine at that point in their cycle.
Okay, so that kind of answers a question that we had, which is, why do I always get a migraine attack at the beginning of my period?
Okay, that's right. So, so like I said, you know, the drop is usually, you know, as the period is about to come on. And so, you know, but people will have, you know, slight fluctuations in their own hormones. And so some people will find that, you know, that the peak time for them to develop a headache will be in the day or two before their period starts. And for some people, it's on the first or second day of their cycle. So, you know, there are definitely some variations from patient to patient. I find it very useful if people have awareness of when they are due to get their headache in relation to their period, because, you know, then, you know, if there is an awareness of that, then we are able to intervene.
Yeah, that's an example of how it really does help to have regular periods and know when you're about to get your period. That's certainly helpful. Obviously, this is a question we all want to know, but does it ever end?
Does it ever end? So yes, actually, for about, you know, studies show that for about 2/3 of women, once they've completely finished with menopause, their migraines obviously the menstrually related migraines, but their migraines overall do get much better or even completely dissipate. So there is hope for, you know, about 66 or so % of women in the population. Unfortunately, that's not the case for everybody, but I would definitely say that, you know, I've been in practice for 12 years now, and I have very small numbers of patients who are postmenopausal, really very small numbers. Yeah. So yes, at some point it does end.
Very encouraging. I know later on we're going to shift to talking a little bit about medications just shortly, but I think some people would be very interested in knowing that if it's predictable, you know that the attack is coming, what are some prevention tips that you can do?
Okay, so there are many things. I mean, many of them are related to having access to medication, prescribed medications, and you know, there are things that you can discuss either with your neurologist slash headache specialist, or with your OB/GYN. So, okay, where to start? So the first, there are various studies that have been done about that, about what we can do as far as preventing menstrually related migraines. So one aspect is something very simple, where you can take something around the time that you're just due to get your period, and it's called mini prophylaxis. So mini prophylaxis meaning not taking a preventative the whole month round to prevent your menstrually related cycle, but really just around the time of your period. And there are studies done with various things, including just over-the-counter naproxen taken twice a day, and some done with various triptans, some, Frova or Frova-triptan, which is the longest acting of the triptans, but also with taking sumatriptan, which is one of the more rapidly acting triptans. It's also known as Imitrex. And these are taken, usually in the clinical trials, they were taken over a 5-day period, starting depending on when your period was in relation to the headache. So for most people, you'd start it 2 days before when you were due to get the headache. So say, for example, if a patient, recognizes that they usually will get their headache the day before their menstrual cycle starts, then 3 days before they would want to start taking, for example, naproxen, and take it twice a day for a total of 5 days. And for many people, that can really help to completely, knock out the menstrually related migraine. So that's one aspect of things that can be done. Mm-hmm. And then, more from a hormonal perspective, there are many different things that can be done in relation to this. And I'll probably be knocking out some of the questions that are coming ahead. But we're lucky we live in an era where hormonal therapy has really changed a lot, over the last 10 or 15 years. Previously, the oral contraceptive pills had very, very high levels of estrogen in them. And for many people, it actually made their migraines significantly worse, either around their period or, throughout the cycle. Whereas nowadays, with the low and ultra low levels of estrogen available in the oral contraceptive pills, many people will find that being on the pill will, especially a low dose monophasic pill, meaning one in which you have a constant level of estrogen release, can help not only to reduce migraine auras, because you don't have that spike that occurs mid-cycle, mm-hmm. but also to alleviate the issue of dropping estrogen levels as your period is about to come. And many patients actually find that if they cycle their pill, what that means is taking continually active pills throughout the month. So just for example, for people who are familiar with being on the oral contraceptive pill, they come in a pack of 28 pills, 21 of which are active and 7 of which are placebo. And so basically what you can do is take the 21 pills and then skip on to the next pack and, just continually take active pills as long as your either your OB/GYN approves you for, or as long as your body will tolerate it without having some breakthrough bleeding. And in that way, you can really eliminate a very large number of your periods and that drop in estrogen, which is related obviously to the headache cycles. So that's one technique that people can use. And obviously you need to get a specific prescription from your OB/GYN for that, because if you just go on just skipping all the weeks, so you need to have the prescription written as one active pill daily, and in that case you should be able to take it on a continuous basis for say 3 or 4 months and only really get your period very infrequently. So that's one tactic that can be used. Another tactic is using something like the NuvaRing. works similarly to the oral contraceptive pill, but it's inserted internally, and you can also similar to taking what I was saying with cycling your pill, you can do the same thing with the NuvaRing without studies that have found that to be very helpful also, even in patients with migraine, which was encouraging to see. And then another thing, is the IUD, specifically the hormonally impregnated IUDs, such as Mirena. Many patients find that they actually don't get a period at all on the IUD, and it's got a very continuous level of hormonal release. And for many patients, that that is a real panacea to not get your period and not have to worry with the aura aspect or the menstrually related migraine aspect.
I know people probably want to dive into the medications a little bit more, but before I transfer over to Eileen again, one question that we have is, do you treat menstrual migraine differently than chronic during a period if you have both?
Well, I mean, I spoke already about the mini prophylaxis. So that would be something specifically targeting the menstrually related migraine. For many people who have menstrually related migraine, well, I say for many people, there is a small subsection of patients who just have pure menstrual migraine, meaning they don't have any migraines at any other point in the month, even if they're totally dehydrated, stressed, sleep deprived. They won't get a migraine any other time of the month. They really are just very, very sensitive to the hormones, and that's their only or their strongest trigger, but far and away. So for those patients, purely using mini prophylaxis can help to alleviate that issue. Whereas for most people who have menstrual migraine, it's menstrually related, not pure menstrual migraine. I guess that's the distinction you were asking before about menstrually related versus menstrual migraine. So it doesn't distinguish between whether it's pure menstrual migraine versus menstrually related that you have at other times of the month, and also especially around the time of your period. So for most people who have menstrually related migraine, it occurs at other times of the month as well. But for many people, it's not chronic. And so they can, they may still qualify for being on a prophylactic medication for their migraines. And then it can be supplemented with the mini prophylaxis, as we just discussed. And this exactly the same would apply for patients with chronic migraine. It doesn't really guide us to one treatment versus another. Like, I don't believe that if you have menstrually related migraine that you're, and chronic migraine, that you're more likely or less likely to respond to Botox or Topamax or any of the other prophylactic medications that we have.
So I guess I have a question or a follow-up question about that.
Sure.
We have so many people within our community who are just really struggling with chronic migraine. And so they do watch how many times a month that they're treating, specifically because they're concerned about going into the medication adaptation headache, or, however you want to look at it. So I think one of the questions that they were probably asking there was, if I'm already taking, say, 9 triptan medications a month, can I also do that mini prophylaxis during my period week or not? Like, is that putting you a little bit too close to the edge there?
So possibly. I haven't seen any specific studies that evaluated the link between menstrually related migraine and using triptans as mini prophylaxis. I mean, in the trials for just that just evaluated mini prophylaxis, they didn't see that it led to more medication overuse or rebound headache. Okay. However, I haven't seen any studies that evaluated both of them concurrently. So I'm not exactly sure how to answer that question, other than to say that we're very lucky that we live in an era where there aren't just triptans as treatments. I was like so thrilled when this other new modality, the CGRP antagonists, came onto the market, giving patients with chronic migraine many more opportunities to treat their headaches. And the great thing about the CGRP antagonists, in addition, to their good efficacy and low side effect profile, is that they also can be used in concurrently with triptans without having any side effects or interactions between them, number one. And number two, there isn't an issue of rebound or medication overuse headache with medications like Ubrelvy and Nurtec. And so those medications, patients with chronic migraine really can actually have the opportunity to treat all their headaches. So I think that helped, that recent developments have really helped to alleviate that from being a major issue.
No, that's actually a really great point because for so many years we didn't have any real options that weren't rebound causing. So I
Oh,
think that's a good point. Yeah.
yeah,
And we are
100%.
living in a
I think
great
it's
time.
really yes, I know. I have to say, it was really shocking to me when I really considered that no migraine specific treatments had come out since the 90s until the CGRP antagonists were developed, which really, I'm not sure how much it says about how migraine was seen as a problem in society, that pharmaceutical companies didn't really find it necessary to focus so much on it. I wonder how much of it is because it's really a woman, significantly more a women's issue than a man's issue.
Yeah, we definitely have feelings on that.
Yeah, so
we could express some opinions on that, but
yes.
maybe we won't today.
Yes, but that being said, I am very grateful for the fact that there are all these new treatments that have come onto the market, because it really has changed the playing for many patients and for the doctors treating migraines as well.
It has, absolutely. Couldn't agree more. Okay, so we're going to move on to a couple of medication and birth control questions. I'll try and skip over the ones that we've already talked about and summarize otherwise. So the first question was migraine nausea medications aren't working for this person apart from diazepam. Now, they want to know what they can do, but diazepam, that's more of that's a benzodiazepine, right? Is that typically used for nausea or no?
No, I actually have not encountered any patients who use it for nausea, so I'm really not familiar with it being used in that way.
Okay.
I would feel uncomfortable about using it on a regular basis, because of its cognitive side effects.
Mm-hmm.
So, I mean, I don't know, obviously I don't know what other medications this patient has tried, but, medications like metoclopramide and Zofran, are just examples of anti-nausea medications that can be very effective for many patients. And I hope that she has explored other options before going for diazepam as a treatment option.
Okay. So we did talk about some prevention strategies as far for, menstrual migraine. And we also talked about frovatriptan, using that days before the start of the period. They're wondering if that is the best treatment or is there a better one to focus on?
There aren't really head-to-head studies comparing, different treatments for mini prophylaxis. So usually what I'll get patients to try is actually naproxen, because it's, cheap. There isn't an issue with insurance coverage,
Right.
and also because there isn't any issue with preventing patients from using their regular acute treatment. So for example, if you are using mini prophylaxis and you're on Frova, but your preferred migraine treatment is Maxalt, then you have an issue with using them on the same day.
Okay.
So, so I will preferentially try naproxen initially for a couple of cycles. And if that's not effective, then I will usually actually try either like low dose Imitrex, like 25 milligrams 3 times a day, or Naratriptan rather than Frovatriptan. Not because I think Frovatriptan is less expensive, but just because in my experience, there are very few patients who are able to get good coverage through insurance. If you're fortunate and you do get good insurance coverage for that, then I think it's a great option. But if it's going to, be tremendously expensive for you, then I would try one of the other modalities first.
Okay. I know my daughter has really good luck with naproxen, so that has been really helpful for her because she also takes elatriptan. So, being able to use those concurrently is helpful.
Correct.
So we talked a little bit about hormone therapy. The question that I have, the question here is, what about hormone therapy? One question that I have is there have been other people who have talked to me about wearing a patch just certain times of the month, like whether it's around ovulation or I'm not sure which. But is that something that you see much in your practice?
I haven't actually seen that.
Okay.
I think it's more used in perimenopause rather than in younger patients, because most people, of reproductive age also want to use it as a contraceptive method.
Okay.
So really, I actually can't think that I've ever had one patient who's used the patch other than as hormone replacement therapy. And there are some studies where it's been used in in perimenopausal patients to help with their menstrually related migraine, but I haven't seen anything in younger patients, which is not to say that there are no studies about that. I just cannot be aware of every single study that's been done on that subject.
Yeah, we definitely don't expect that. Another question that was asked is, are there some types of birth control that are more effective for menstrual migraine than others?
Sure. So I mentioned before that the preferred method is using like a low dose monophasic, meaning one with a very low dose of estrogen and constant release of taking the same dose of estrogen in each tablet. This is compared with another type of oral contraceptive, which is often used, called tricyclic. And these have got different doses of estrogen during the month, and that's obviously something that you really want to try to avoid if you have menstrually related migraine or any type of migraine, really.
Okay. And then the last question for this category is, now I sound like I'm on Jeopardy or something.
Yes.
If you have migraine with aura and menstrual migraine, should you avoid birth control with estrogen?
Okay, that's a good question. So it's actually a controversial question, and I'm not going to be able to give a completely definitive answer to that because there are different opinions. If you were to ask your OBGYN, the official recommendations from the American Academy of OBGYNs is that it should not, estrogen-containing oral contraceptive pills should not be used in patients with migraine with aura. But there have been, a few articles written about the origin of that recommendation. And basically a lot of the studies that were done that found a strong relationship between either, heart attack or stroke and being on the oral contraceptive pill were done in an era where the oral contraceptive pills had far, far higher levels of estrogen in them, between 50 and 100 micrograms, and the newer ones have got 10 or or thereabouts, exactly. So it really is dramatically different. And even in more recent studies that have looked into this, when they discriminated between the patients who were on higher and lower dose of estrogen, literally all of the strokes were in patients who were on higher doses of estrogen. So, even though the low dose oral contraceptive pill might have a very, very minuscule chance of increasing your risk of heart attack and stroke, and having migraine with aura might very slightly increase your risk of heart attack and stroke, the combination is really only significant in patients who are smokers or have other significant risk factors for heart attack and stroke. So, when I looked at, recently revised looking at these studies, and what I saw was that it was all patients on high doses of estrogen and all smokers.
Okay. Yeah.
Yeah. So, I mean, I think that even if you didn't have migraine with aura, your OBGYN would definitely be hesitant to put you on the pill if you were a smoker or had other, significant risk factors like, diabetes and hypertension or very high cholesterol. And so, all those things not being factors, I actually feel comfortable with putting, by nature, I'm a very cautious person, and I'll always discuss it with the OBGYN before making that recommendation. But I am comfortable with people, especially people with like low frequency of migraine aura, being on a low dose oral contraceptive pill. And in fact, one of the studies that was done on specifically migraine with aura was using continuous NuvaRing, which is also, continuous exposure to low dose of estrogen, and there was no increased risk of heart attack and stroke in that study. That's
interesting.
Yeah.
Huh. Okay. Well, Danielle, you want to talk about some questions about perimenopause?
Yes. As you know, perimenopause is a time that we often see an uptick in migraine. People say that sometimes they used to just get their attacks around their period, and now they're getting it mid-cycle, so perhaps around ovulation. So can you share some helpful strategies for when you are going through perimenopause?
Sure. So, there are some studies that we discussed briefly. The patch, like continuous transdermal estrogen, which can be used both, in the perimenopausal period and also in the postmenopausal period. And there are some studies that show that can help with not only with the like perimenopausal symptoms, but also with menstrual-related migraine. So that is something to consider. And then also there are like these, it's called LNG-IUS. It's like an intrauterine system with like low dose release of estrogen derivatives. And that can be effective also as contraception, and also in reducing menstrual-related migraine. So those are a couple of options that can be used. Obviously it should always be discussed with your OBGYN, because there are risk factors in being on kind of like low dose estrogen as well, especially as you get to older age. So so it really is kind of a risk benefit ratio to discuss with your OBGYN. And then other things that can be used also, there's some studies that show that venlafaxine can be helpful also with the menopausal symptoms, as well as with the menstrual-related migraine, and escitalopram as well, which are both non-hormonal options, like low-dose antidepressants, which can be used in regular migraine as well. But there are specifically studies that show that can be helpful for the menopausal symptoms and menstrual-related migraine.
Good.
That's great. But you've given us so much information already. Some of these questions have already been answered, but we've also had a lot of people, a lot joined since you first gave the good news about menopause. Can you again share the statistics for what happens after menopause?
Oh, sure. Okay, no worries. So, so the good news is that for 2/3 of women, that their migraines get dramatically better, or even go away completely after menopause. So, hopefully that'll be the case with everybody who's watching here, and myself.
And I know we had somebody made a comment that their attacks are dramatically worse since menopause. So I think we'll probably at some point have another talk. But can you talk a little bit about what happens, or what your thoughts are when you hear of somebody getting worse in menopause?
So I'm not sure if I didn't see the comment, but did the person say that their headaches got worse actually post-menopausal or in perimenopausal? Because it's very common for people's migraines to become worse in the perimenopausal period. The same as in adolescence. It's a time of like a lot of fluctuation and hormonal change, but it's very unusual for it to occur post-menopausal.
I definitely have talked to several people who are within our group who've said that they've gotten much worse after menopause, like after they were already through. So
I mean, if that was the case, if it was a patient of mine, I would always want to just investigate and make sure that there was nothing else that could be contributing to it.
Okay.
It definitely could be the case, but usually it's the fluctuations in hormones which make it much worse. The same as for most people during pregnancy and breastfeeding, that, with the hormonal stability, that the headaches also become much better. And I think I'd be a little concerned if they got dramatically worse, and, just make sure that there was nothing else that could be contributing, like maybe an underactive thyroid or something else that, that could be driving the increase in migraines during that time period.
Okay, I did scroll through the comments, and the person did note that it was significantly worse after. So your recommendation would be to just pursue what else could be going on then?
Yes, I mean, I'm not saying that there's definitely something else, but I would, like a spike or change in headaches or onset of migraines out of the usual, time period in which people have onset, which is like teens, 20s, 30s, 40s, would be a reason to trigger an investigation and just make sure that there was nothing else underlying it.
Yeah, we frequently point people in that direction when they talk about the changes in their attacks or whatever, is to definitely follow up with their doctor about that.
For sure.
Well, that's it for my questions about perimenopause and menopause. I know that we have a lot of people interested in some non-medication approaches. So Eileen, go ahead and
okay.
Those.
Sure.
All right. The first question that we had is, are there any supplements to prevent or ease menstrual migraine symptoms?
Okay, so so the supplements that are that are used are mostly used for regular migraines as well, whether you have episodic or chronic migraine too. And there are quite a few studies that have shown some evidence for improvements of your migraines on these medications, or on these supplements. So the one that's spoken about really the most is magnesium. So magnesium in doses of usually about 400 or 500 milligrams a day have been shown to be helpful. So that's something that is usually very well tolerated, inexpensive, and easy to try. The most common side effect is that some people will get some diarrhea. Occasionally, people will get diarrhea on it, and if that's the case, you can discuss with your doctor and switch to a different formulation, which might be less likely to cause that.
Right.
So that's one option. Another alternative is vitamin B2. Also known as riboflavin. The dose of that is around 400 milligrams a day. It turns your urine very yellow, but other than that, doesn't usually have side effects. And that can also be effective at preventing migraines. I should just mention, actually, with any of the vitamin supplements, that you need to be very patient with them. Similarly to the oral preventative medications, which can take up to 6 weeks to kick in, and that's not something which is always conveyed to patients. Like I had a patient who I saw last night, actually, who said to me that I started gabapentin and it's done nothing for me, and he'd started it less than a week ago.
Yeah.
And it usually takes about 6 weeks for it to kick in, and even more so with the vitamin supplements, they can take about 3 months before you can really see a change. So don't expect anything dramatic or immediate when you first start them. Other alternatives that can be used as like as vitamin supplements to prevent migraines. So CoQ10, there is some evidence that can be helpful. The dose is 300 milligrams a day. I've seen it sometimes dosed 3 times a day, but I think that 3 times a day dosing of any medication is an automatic failure, because nobody's going to be compliant with that throughout their life.
Yes.
So I usually just dose it once a day. It can interact with a couple of medications, so definitely worth discussing that with your doctor as well, which other medications you're on. Feverfew, there's also a little evidence that can be helpful. And vitamin E, there are some studies specifically for menstrually related migraine that can be helpful as well. It's 400 is the dose that was used in the studies that I've seen. And the way that it was taken was starting 2 days before your period and taking it for a total of 5 days. So that was the only one that I have come across that specifically has been found to be helpful for menstrually related migraine. And then over the years, there have been a few studies that have come out about butterbur as a supplement for not just for menstrually related migraine, but for all types of migraines. The issues with butterbur is that part of the plant can be toxic, and there have been a few documented cases of people developing liver toxicity on that. So most headache specialists are not recommending. It's not really a good trade-off to lose your liver to improve your migraine.
No, definitely not, for sure. Vitamin E was one of the questions that people had. I know that we had several people within our group give it a try and then report back to us, and most of them had some good relief from it. So I was surprised by that, because I hadn't read that study prior to somebody bringing it to my attention. So I thought that was really interesting.
Yeah.
And
harmful, inexpensive, and easy to take as a supplement to whatever it is that you're using to treat your headaches.
Right. And I do think that it's really important that we remind everyone, we don't know what kind of medications you're on or what other health conditions that you might have. So before you go out and buy supplements and try them, definitely make sure you talk to your doctor about it to make sure that it's not going to interact with the medication that you're taking, or if it's not good for your kidneys or whatever, if you have chronic kidney disease. So anyways, that's just a little aside there. So another question that was asked was quick food to focus on when you have nausea from menstruation and migraine together. And I don't know if there is a specific food that's best, but I will say that goldfish crackers are like my go-to. And I talk about it all the time. I feel like they're this magical food that always gets rid of my nausea, but maybe you have another recommendation.
Well, I'm not sure that I have anything specifically for nausea. I mean, I guess it would be similar to what people try when they have pregnancy-related nausea. So, many people find the kind of salty crackers and that kind of thing can be helpful. But really the most important thing from my perspective would be trying to stay well hydrated. Because if you are having nausea, and you're less like, then you're much less likely to stay well hydrated, and therefore more likely to trigger a migraine also from becoming dehydrated. So I really would try to focus, on good hydration with non-caffeinated drinks.
Yeah, I see one down here. Somebody mentioned mint tea, which we know that mint can be very helpful with nausea as well. So that's probably an option as well.
Ginger as well.
Yeah. Oh, we sing the praises of ginger every day. I swear we talk about that more than anyone. And then another question is, how do foods and food additives interact with menstrual migraine? Do you see that as something that's an issue?
Yeah, so not specifically just with menstrual migraine, but there are many foods. If you look online, you'll find these enormous lists of a plethora of different things that can supposedly trigger migraines. I would say that the vast majority of things that I see on those lists, I've never ever had a patient say to me that they think that it triggers off a migraine for them. But the most common food triggers that I usually discuss with my patients, I think these are the most common and potent ones. Aspartame, also known as NutraSweet or Equal, it's in diet sodas and sugar-free gums. So I don't recommend people just avoiding it around the time of their period unless they have like pure menstrual migraine. If they do have pure menstrual migraine, then you can just avoid it around the time of the period. But for other people, I would really, just recommend avoiding it constantly.
All the time.
Yeah, exactly. Nitrates, which are preservatives used mainly for meat, like cold cuts, hot dogs, sausages, bacon, that sort of thing. They've also been, found culpable in causing cancer. So it would have good to avoid them anyway. But and nowadays it's actually very easy to find nitrate-free brands of cold cuts, etc. So that's the second thing. So this is not a food additive, but gum. There was some studies done on Israeli teenagers that found that gum chewing can trigger off migraines. So
really?
Recommend trying to avoid that. Look, we also know that TMJ and clenching and grinding your teeth can trigger off migraine. And, the action of gum chewing is very similar to what people do when they're clenching or grinding their teeth when they're anxious or sleeping.
So that's more of a mechanical issue.
Yeah.
Okay.
Exactly.
Got it. Okay.
Yeah. So, it can be compounded by it being sugar-free gum, because then it's probably got aspartame in it.
Right.
So it's the double whammy. Exactly. And then also MSG. There's some controversy about MSG, but I do have many patients who believe that MSG triggers off their migraines. So I do recommend for people to try to be conscious of that and avoid it if possible. And then the last food that I usually discuss with patients also is red wine. We think it's from the sulfites. I guess that's sort of an additive. It's not something that's intentionally added into the wine, but some wines have got higher levels of sulfites in them, and that can be a migraine trigger as well.
Okay. That's all very good information. And red wine used to be a problem for me before I was well controlled. And so I think sometimes that plays a part in it, right? Where if you're out of control and you're having migraine attacks daily, then chances are you might be more affected by some food triggers, as opposed to when you get a little bit more control. Maybe it doesn't overflow your bucket.
100%. The way I describe it to patients is that, when your brain is hypersensitized, basically any little trigger can trigger off a migraine. When things are under good control, or when you just have very infrequent migraines, it might take several different triggers to lower your threshold to a low enough level to trigger off a migraine.
Right.
But we know why that occurs. There's this phenomenon called central sensitization that occurs in your brain, which basically means that pain pathways become hypersensitized, and then any little trigger or even no trigger can trigger off a migraine, just because those pathways are so accustomed to firing off. So in your case, thankfully, it sounds like your headaches are under good control. So, maybe you can tolerate, exposure to triggers like maybe stress, or, not sleeping so well one night,
right.
Or drinking a glass of wine, which previously might have, been enough to trigger off a migraine just in and of itself.
Yeah, for sure. So,
and I think it's interesting often, when we discuss with patients, whether they're having a good response to a preventative medication, usually we talk about it in terms of frequency of headaches and how disabling they are. But, what we don't usually have time necessarily to discuss is, can you go out and have a glass of wine with your friends?
Right.
And that's a much more subtle measure of whether the medication is effective for you or not. But it is also, kind of impactful in your life if you're able to, to live a more fulfilling and less fear-filled life, not so scared that one glass of wine is going to set you off for 3 days of migraine.
Yeah, that's actually something Danielle talks about all the time is, being able to be social and how that, can raise your quality of life, even if you are, suffering with migraine quite frequently. So it's good to hear you say that as well.
Thanks.
Now, I'm scrolling through some of the questions, and I'll try to keep them more toward this topic of hormones, because we do want to have you back if you will do that. One of the questions was for, I'm assuming they mean, are triptans your treatment of choice for menstrual migraine typically?
So for many prophylaxis that we already discussed that I use either naproxen or one of the triptans. I don't have a preference when it comes to, as the acute treatment, meaning the medication that you take when you have a headache, for a triptan versus a CGRP antagonist, or even versus, some patients respond really well to one of the prescription anti-inflammatory medications like, Cambia or flurbiprofen. There are several different ones on the market. So I don't really have one preference for any of those medications over another. Part of what we unfortunately have to do is abide by the requirements of the insurance companies. And, for a patient, even if they are, like, for example, very nervous about potential side effects from triptans, insurance companies will not cover them to try a CGRP antagonist unless they've had, failure of response to either one or two triptans previously. So that kind of also helps to dictate what our treatment options are. But
yeah, that's true.
I think that all modalities can be helpful for some patients, and often it can be a little frustrating, but it's a matter of trial and error until you find the right one that works well for you. And we don't have some way of discriminating that this person will respond really well to Maxalt, and whereas elatriptan or Relpax will be great for this patient, and this person will do better on Nurtec or Ubrelvy. So really, it's just a matter of trial and error.
That's very helpful. We do have another hormone-related question, and I don't want to wait until we have another talk with you, because I think she's probably trying to conceive and would like to know of medications that are acceptable. She said which can't she have, but maybe it's better to focus on which are the more acceptable medications to use when you're trying to conceive.
Mm-hmm. So that is actually a much more complicated question, and not something that could be answered in a minute or two. And it's really a conversation that you'd have to have with your headache specialist in combination with your obstetrician, because the answer is very different for different people. I'll just give you an example. Like, let's say a patient who has epilepsy. Ideally we would want a patient to be off their epilepsy medications if they have migraines, but if they have epilepsy, it might be much safer for them to remain on their epileptic medications during pregnancy. And similarly with antidepressants, a patient who is on an antidepressant that also helps their migraines, if they're going to slip into terrible depression if they come off that, then that would also come into play. So there isn't really one answer to give to that. The other aspect is that regardless of what your what your headache specialist says about this, at least for me, I always really will defer to the OBGYN, because I feel like their kind of prime responsibility is to take care of the mother and baby's health during their pregnancy, and I would never recommend anything that could potentially step on their toes. And OBs have very variable levels of comfort. I've had OBs who've said that they want their patient off every medication and the only thing they can use is Tylenol. And then I have other OBs who are okay with their patients taking triptans and being on Botox. So it really is a much more complex discussion. And, hopefully when we have another meeting, we can discuss also about like what you can do when you're planning for pregnancy and, different things to take into account. But unfortunately, it's not, just a brief answer that I'd be able to give right now.
Okay.
Well, thank you so much. We really, truly appreciate your time, Dr. Lisa Yablon. I know that you have a patient coming up for Nora Health, so we want to be respectful of your time and just express how appreciative we are that you took this time to specifically focus on menstrual migraine. I think you helped a lot of people here. A lot of people were saying in the comments that it was good timing because they actually have menstrual migraine today. So, so I think your words of wisdom are very timely and appreciated. So thank you.
All right. Thank you. Thank you so
Absolutely.
much. Thanks for having me. I
Okay.
really
Take care.
appreciate it and enjoy